welcome everyone to this week's DDU focused cases, and we'll be recording some cases that are hopefully useful with regards to, I thought we'd go over diastology this week.
So a 74-year-old man with pneumonia, met call on the ward for hypotension, comes to ICU, intubated, ventilated, past history of diabetes, hypertension, day 6 improving overall, trial of CPAP, pressure support failed, tachypnea, hypoxia, echo to look for biventricular function.
Cool. All right, so we comment on these, Ravi. Tell us what you see.
So should I go with one image at a time or overall?
Yeah, maybe start with this one and then sort of work around clockwise.
Yeah, so left top one is the parasternal long axis, which shows anteroseptal and inferolateral walls, and LV systolic function appears normal with normal contractility. I can see left atrium which appears dilated, and
Yes.
there's thickened aortic cusps and slightly thickening of the mitral valve leaflets as well, bit of calcific spots.
Yeah.
And,
what would you call this, Ravi, where my cursor is?
that's the posterior mitral leaflet with a
Yeah.
bit of calcification there.
Yeah, so posterior mitral annular calcification or posterior MAC. And as you say, in some calcification on this
Anterior leaflet.
person. Yeah, nice.
And so even the aortic valve cusps may not be opening that well.
Yeah,
They're
agree.
not completely opening.
Yeah.
On the parasternal short axis, this is at the basal level because I can see the mitral valve leaflets, and I can see normal systolic function, good contractility.
Yeah, you're getting a bit of drop out of this wall here. What would these walls be?
So anterior and anterolateral wall.
Yeah, nice. Okay.
Then left bottom is the apical four chamber view, which is showing very much dilated left atrium. The left ventricle appears to be contracting well, so good systolic function. I can see a bit of calcification on the anterior mitral leaflet. I can't see much of the posterior mitral leaflet, but hopefully they're opening well.
Yeah, and it's quite angular.
On the right side, I can...
The calcification,
yes.
right? And there's a little bit on
Yes.
the tip, as you say, but it's mainly annular. Calcification. Yeah. How about the right atrium?
Right atrium appears big as well. However, the interatrial septum is still moving onto the right side. So
Nice.
Probably elevated left atrial pressure.
Very nice.
And right ventricular size appears normal on this view. And the last view looks like apical two chamber. There's a drop off of the anterior wall, and I can't see the apex. A bit of basal inferior wall can be seen. Again, we can see the annular calcification, and can't see the mitral valve leaflets very clearly. And again, the left atrium appears a bit dilated.
Yeah. All right, Ravi, these are the Doppler profiles. Maybe start here again and we'll work our way around clockwise.
Okay, so the left top is the pulse wave Doppler at the tip of the mitral valves, and it shows E to A ratio, let me see, more than 2. So that's like a restrictive pattern. So it would be grade 3 diastolic dysfunction. E to E prime is the average 13.5. So that's more than 10. So it's not 14, but it's tending towards diastolic dysfunction as well. And mitral deceleration time is very low, 97.
The decel time, very nice, very nice. And what are your normal values for medial and lateral E prime? I know we've just gone over it, but just to re-emphasize.
Yeah, medial E prime more than 7, and lateral more than 10 is normal.
Yeah, centimeters per second. Very nice.
Centimeters per second. Yeah.
Yeah, good. And what's a normal value for your left atrial volume index, Ravi? Ravi, what's your cutoff?
34 mils per meter square indexed.
Very nice. Yeah, yeah. And what about your TR cutoff in the guidelines, the TRV?
More than 2.8 meters per second.
Very nice. And before we go on to sort of talk about the grading of diastolic dysfunction here, just talk to me about this Doppler trace.
So that's a continuous wave across the mitral valve.
Look, maybe
And,
have another look through that at that, Ravi, where the color box is and where the sample volume is.
I can't really see where it is. Oh, is that pulmonary vein?
Yes.
Yeah, it's at the pulmonary vein. Sorry.
What pulmonary vein is it?
So that's the upper.
Right or left?
Right up, left upper pulmonary vein. Sorry, right upper. It's close to the right atrium. So
Yeah,
right
very
upper
nice.
pulmonary vein.
Very nice. Yeah. Yeah. And what can we see?
So diastole, yeah. There's diastole is much more than the systole. So
Very nice. Yeah.
all point towards elevated left atrial pressure.
Very nice. There's hardly any S wave at all, is there, to do your sort of S to D ratio? So if you can all see that, so we've got this is our pulse wave Doppler through the pulmonary vein. Normally we'd have a nice S wave, which I'll show you some pictures of, followed by the D wave, which is generally smaller than the S wave. But here we have complete systolic blunting, i.e. we have very, very little / no flow in systole. It's all restrictive in diastole from the pulmonary veins into the left atrium, which, as Ravi was saying, in this context, from what we can see, you know. So do you want to just suggest raised left atrial pressure? So do you want to summarize those 2D findings, Ravi, and the things that you mentioned that were pertinent from your 2D findings, and then combine that with the key features here that are telling you, that are allowing you to make a conclusion about diastology?
So mainly from 2D, only significant finding was a dilated left atrium.
Nice. Yeah.
And we did have some annular calcification at mitral valve, maybe some at the aortic valve. But there was no thickening of the left ventricle, and the left ventricle systolic function was normal.
Yeah, absolutely. You mentioned about the intra-atrial septum bowing across to the right as well.
Right, yes, that's right. Yeah. So
yes. That's a nice safety marker, isn't it?
Yes. And on Doppler findings, so there is E by A more than 2, so 3.34, and E by E prime is 14, and left atrial index volume is more than 34. Plus we have systole blunted and diastole more than systole in pulmonary venous Doppler.
Very nice. So Ravi, in this patient, what do you need to look at any other parameters really if you have the E to A of more than 2?
We can still have that like as we discussed in athletes, like if the patient was young and athletic, so we still need the E to E prime. And
this patient is young and athletic. This one.
No, sorry, that's a 74-year-old. That's right.
Yeah, very nice. So this for me is a nice example of where you've got that normal ejection fraction, but it's not structurally normal, is it? So they still go into that second algorithm in the diastolic dysfunction guidelines, because we've got, you know, significant structural changes there. We've got significant mitral annular calcification. We have big dilated atria. Maybe there's a little bit of LV hypertrophy. It's difficult to know without measuring out. And there's probably some significant aortic valve disease as well, even though we're not focusing on that in this case. But so you would absolutely be in that second algorithm, because if you're in the first algorithm, you couldn't use, it doesn't include E to A, does it, in terms of getting you between diastolic. Essentially, that first algorithm is just telling you, is there diastolic dysfunction, yes or no. The second algorithm is for, there is diastolic dysfunction, I need to grade it, i.e. I need to know whether it's mild and there's just impaired relaxation, not just impaired relaxation, or whether it's moderate to severe and there's raised left atrial pressures. That's what we're really wanting to know. So in this case, we can go straight to our second algorithm, which really means you only need to look at your E to A ratio, don't you? And if that's more than 2, you go straight down that arm of likely raised left atrial pressure, and combine that with the fixed bowing of the septum, intra-atrial septum to the right, and the clinical sort of history, what you're dealing with, which is weaning failure. You're very likely to be dealing, right? So it's about bringing back in, and this is what they'll want you to do in the Viva, Ravi, is bringing back in the clinical scenario.
Clinical context.
Yeah, right. So you've got failure of weaning, essentially, and we know that one of the relatively common causes of failing to wean in the ICU, I suppose, is diastolic dysfunction, isn't it? So it's about bringing that in. I think there might be a little bit mean to give you a case like that, but I think it's still a good one. So yeah, just sort of bringing all of that together, and then we can talk through that second, like the middle part of the algorithm where we would use these things. Another important thing to mention in this case, which is what you picked up on, is the mitral annular calcification. If you added something like, I'd be a little bit hesitant to use those E prime values, because I know they're going to be artificially reduced because of the mitral annular calcification. Therefore, I wouldn't hang my hat just on an E to E prime value. I'd want to look for other surrogate markers, bowing of that intra-atrial septum, what the pulmonary veins are doing, whether there's any B lines in the lungs, right? I think that would take you to the next step, because you've shown that you've recognized some of the caveats of the mitral E to E prime with tissue Doppler. If you've got heavy mitral annular calcification like this patient, it might not be as reliable. Obviously, the trend in the individual patient is still useful.
So we can still call it a structural heart disease based on calcifications. And
if you've got, I mean, for me, if you've got thick ventricles, if you've got big biatrial enlargement, if you've got valvular disease, they all fall into the this patient is going to have diastolic dysfunction, with atria that big and everything. And I just want to know what grade of diastolic dysfunction they have. Yeah, the guidelines don't lay it out. They don't say specifically exactly what structural heart disease, but I think, anyone with diabetes, hypertension, thick ventricular walls, structural valvular disease, big dilated atria, and sort of small LV cavities, like the classics of elderly patients, they're going to have a degree of diastolic dysfunction. Just trying to figure out how severe it is. Yeah. So what do you think of this is the patient's lung ultrasound, Ravi.
So on the top two, just left and mid axillary, left middle lobe anterior and mid axillary, showing more than 3 B lines per field. So probably this patient is in fluid overload. And then the lower bilateral, so lower one show left mid axillary and right lower lobe. So both sides we can see the diaphragm, and then echo-free space between the lung and the diaphragm. So that's pleural effusion bilaterally with a collapsed underlying lung.
Yeah, nice. And this is a little patch of collapsed lung on there, and here as well. Yeah, you can definitely see more than 3 B lines here. Hey, those sort of rocket lines going all the way from near field right down to the end of the sector. I'm not so sure on this one. Maybe there's confluent B lines, and that's why we're not seeing that lovely separation. Does our respiratory consultant lung expert want to chip in on this? Anything to say?
Yeah, I mean, I think I would say that there's pathological B lines in both. In the left middle lobe, there should theoretically be a few less than the left lower lobe, just from gravity and dependency. But I'd say there's a bilateral interstitial pattern and bilateral simple anechoic pleural effusions.
Yeah.
But yeah, I think that they probably are closer to just being all merged.
Confluent on this one, yeah, and a bit more.
Yeah, because you can't see any A lines in either of them, especially in that left side. So maybe it's just actually one giant B because they're all together.
And the important thing is that this is all fitting, our patient with a heart like this and a rip-roaring left atrial pressure, pulmonary venous hypertension, congestion, wet lungs, etc. So in terms of how you might manage this patient next, any thoughts from anyone? So you've sort of put together your clinical assessment with your echo and lung ultrasound. In conclusion, Ravi, just putting that together, just give me a 1-sentence summary, Ravi, of your findings.
So basically, this patient is failing, meaning because he's in fluid overload because of grade 3 diastolic dysfunction. So we'll have to achieve a negative fluid balance and keep him slow,
Very nice.
depending on what his whether he's shocked or not shocked. But aim a negative fluid balance and keep him slow.
Yeah, very nice. I think those are the key principles. I completely agree. So in summary, he's got, severe, as you were saying, diuresis, maintaining sinus rhythm, avoiding any tachycardia, and potentially, depending on where you're at. I think he was in the improving trajectory of his ICU stay in that sort of defervescing weaning phase. So, if he's got a high hypertension and things like that, you might want to introduce some afterload reducing agents. And then the diuretics might be enough for the pleural effusions, or we might need some chest drainage just to help him along with that. And I think repeating echo is important in this patient group, and then especially if you're going to repeat the spontaneous breathing trial or continue with your wean, you really want to just look to see how your interventions have helped with the diastology and particularly with the left atrial pressure. And these are the kinds of patients, I suppose, that we probably eventually want to extubate to CPAP. There isn't a great, as we all know, there isn't a great panacea in terms of an inotrope to particularly help with these patients, but there is some mention of levosimendan in the literature. Obviously, it improves those markers of relaxation and diastology as well. So, but there isn't any great robust evidence for that, and it's all on an individual basis. But the key thing is to recognise that you've got, if you weren't trained and doing the DDU and things, you might not assess the diastology, and just look at that LV and think it's not an LV problem. He's got normal systolic function. He can't be failing because of a heart problem, but clearly he absolutely is. And there is pretty good evidence to back this up with Sanfilippo is the godfather in all things diastology and crit care stuff, isn't he? And they showed in this meta-analysis, I think it was about 11 studies actually, I can't quite remember, but they showed that patients with a higher E to E prime, lower E prime values, higher E wave values, and increased ratios of that, so higher E to E prime ratios were associated with weaning failure, much more so than LV systolic dysfunction. And there was no cutoffs that they could derive from these studies, but I think in some of the individual studies, values of around that 50, sort of 14, 15 mark above that tend to be more associated with weaning failure. And yeah, maybe more studies in this area are needed, I think. All right, we have a second case. Would someone like to take this one?
Yeah, I will.
You got it, Ben? So maybe because on the Viva, they'll get you to read out the vignette. So it's worth just going through that.
Yeah, so
quite brief.
80-year-old female, background hypertension and chronic renal failure, urosepsis, had a lot of fluid in ED. She now wants some aramine. Sorry, is that one on the left meant to be playing, or is it a still?
No.
It's a still? Okay.
I will play it after this one.
Oh, yeah, right, okay, cool. All right, so the concerning things on this apical 4-chamber are severe biatrial dilation with fixed interatrial septum bowing to the left. There's thickening of the left ventricular myocardium, trabeculation of the right ventricle, reduced mitral valve opening, and probably a fixed posterior mitral valve leaflet. So she's likely got mitral regurgitation. She's got some structural heart dysfunction, and I expect to have diastolic dysfunction. Her right ventricular contractile function longitudinally is probably reasonable, but given it's dilated, including at the annulus, so it looks to be dilated at the annulus, she's going to have some tricuspid regurgitation as well.
Very nice, Ben. Let's play this one.
Now, what color Doppler scale is at 60. So she does have posteriorly directed eccentric mitral regurgitation, likely due to some tethering of that posterior leaflet. It's eccentric, and there's a Coanda effect down extending into the right upper pulmonary vein. And then I'm getting some flow convergence extending into the left ventricular outflow tract. I'd like to get a 5-chamber view to better assess that and see what the nature of the aortic valve is, as well as the rest of my views. But I'm certainly quite worried about the amount of fluid we give this woman with dilated atria, thickened left ventricle, and significant mitral regurgitation.
Nice, Ben. So what do you think the etiology of the MR is, likely, based on what you've seen so far, like the mechanism?
So I'd say there's 2 potential mechanisms here. One is annular dilation, so left atrial functional mitral regurgitation with a dilated atrium. She's in atrial fibrillation, isn't she?
Mhm.
Yeah, okay. So atrial fibrillation is a potential contributor to that, or a main cause of that. Given that she's got severe renal disease and some hypertension, left ventricular hypertrophy and thinking as well, there may be some myocardial ischemia in her past with an ischemic insult to cover that posterior leaflet and giving some tethering there. But I think given it looks like there's the zone of apposition or coaptation of that mitral valve looks to be more towards that posterior side, I think that she's got a dilated annulus.
Yeah, that's nice, Ben. I agree. I mean, you need to obviously put everything together, but it seems like it's probably going to be a combination of atrial functional MI, isn't it? Because the atria is the size of a house, but also there is a little bit of tethering, and there's significant, again, calcification, not uncommon, right, in chronic renal failure and hypertension. So there's probably going to be a bit of degenerative mitral valve disease as well, hey, or calcific mitral valve disease combined with annular dilatation. And exactly as you were saying, you know, even just based on this colored jet, you can say there's significant flow convergence. The vena contracta looks like it's going to be relatively broad, though it's hard to tell. And the jet area is filling, you know, significant proportion of a already severely dilated left atrium. It's hitting the back wall, and it looks like it's going back down into the pulmonary vein. These are all in keeping with what looks like, you know, could be what looks like severe mitral regurgitation. And you might have picked up on something else that you can see just playing in this loop, Ben, another type of valve pathology that's coming through.
So can you scroll back?
Do you want me to just do that in real time?
So it looks like this she's going to have mixed mitral valve disease. It looks like there's some splay and potentially a small PISA in the left atrium during diastole. And then also there's a flash of green that I think is in systole, need to slow down, that's extending into the left ventricular outflow, or coming out of the left ventricular outflow tract, which may be some aortic valve stenosis, which I would expect in this woman, given her comorbidities.
Do you think it's in diastole or systole? That's the frame there.
So that is in diastole.
Yeah.
The mitral valve's open, so that would be some AR.
Yeah, exactly. Yeah, it's AR. Nice. Good. All right.
Giant.
Comment on this. Yeah.
Severe atrial dilation. Where's my index volume? It's not that there isn't. No, so that's just my measures. Oh, yeah. That's not index though, is it?
No, it's not. But I've give you the body surface area down.
Actually, right. So it's going to be what, 63.
Assume that's a biplane. Yeah.
Yeah. So normal is 34 or less. And then just in terms of like the axial, I think the area, they say average area or greater than 20 centimeters squared, I think, for the area. If you're doing it the cheap or the easier way. And then the length is like what, 40 millimeters or something. I don't know those ones, but I just go by the volume.
I don't know. I don't know the length, but yeah, I just work with volumes. I think prior to the 2016 ASC update, the diastolic update of the guidelines, they actually used 28 mils per meter square as a cutoff, and then they changed it to 34. So 34 is still pretty big, even though it's the cutoff used in obviously for diastolic dysfunction, obviously to try and improve sensitivity, specificity, and stuff like that. But hers is clearly massive with a body surface area of 2. And assuming that's biplane, it's not, it's just 4-chamber, but the biplane was somewhere around that. So yeah, over 50. So it's really important, and this is obviously not necessarily for your DDU vivers, but generally in your clinical practice, to not foreshorten your apical views, because you're going to really underestimate your left atrial volume index. So you need to go off axis with your LV, because the longest axis, where your longest length is of your atria, is often at a slightly different axis to the LV, and there's a bit of literature on this that you can read about later, but it's really important not to foreshorten them. And as a rule of thumb, obviously you're going to do volume in apical 4, flip around to your apical 2, do your volume there, and then you're going to have your biplane volumes. And as a rule of thumb, the length in the 2-chamber should be the same length as in your apical 4-chamber. And that's it, just like you do with your LV with the Simpsons, and you're not foreshortening, you need to just check that as well when you're doing LA volumes. And obviously not including pulmonary veins and atrial appendage in that cavity. You need to exclude them. And a nice little pearl to remember, which I learned from Faraz Pathan, one of our cardiologists, and he brings it out a lot in like the most beautiful cases where it's really on point, that the left atrial volume is obviously the HbA1c of left atrial pressure. So if you've got if you've got a big left atrium, then it's likely that you've been, that patient has been exposed to high left atrial pressures for a while. There's other causes, of course, things like mitral valve pathology and atrial fibrillation, but it's generally a good rule of thumb. So if you see a big left atrium, unlike the big right atrium, your left atrium takes a little while to remodel, and so whatever's caused that is likely to be going on for a fairly long time. We talked about the bowing. That Ben critique this for your patient.
Yeah. So we've got a pulse wave of the pulmonary vein, the right upper pulmonary vein. Okay. So we've got systolic flow reversal in the wave I can see most clearly. Yeah, I think we can. It's not a perfect trace. In my color.
How could you improve it?
So I think there's a few things we need to do to improve this image. In terms of the alignment, from what I can see in the B mode above it, that looks quite good. We're quite down the gun barrel of it, so to speak. I take the low pass wall filter off so I can see better how things line up. I would change the sweep speed out to only have 3 cardiac cycles. And then I would increase the gain a little bit. I don't want it to be overgained, but I think it could be increased a little so I can try and work out where the bottom of those waves is.
Yeah, nice. And sometimes reducing the depth on this, putting some color into that pulmonary vein, reducing the scale right down, and then increasing your actual sample gate volume as well to about 4 millimeters can help just sort of optimize it. So just a quick recap of the pulmonary veins and the physiology of that. So obviously your pulmonary veins are emptying, there's 4 of them generally, but there can be more different ones, but generally 4, right upper and lower, left upper and lower, and they empty. And then if we put pulse wave Doppler essentially into the pulmonary vein, which is up here, then in systole we get flow from the pulmonary vein into the left atrium. All right, so this is flow coming in through the pulmonary vein towards our probe, hence above the baseline in systole. And we tend to get, you don't always see this, but generally you get this sort of S1 and S2, but essentially you get forward flow in systole. And this is mainly determined by your rate of LV relaxation, but also by how good your right ventricle is and what the cardiac output and things are as well. And then in diastole, we also then get flow coming towards the probe. That's just skipped on. In diastole, so that's again still filling from the pulmonary vein into the left atrium in diastole. And this is mainly determined by LA compliance and LV compliance and those are the sort of main determinants of that. And then of course your atria contracts and you get this backwards flow of blood from the atrium back into the pulmonary veins, hence you get this AR wave below the baseline. So that is a normal pulmonary vein pulse wave Doppler, and generally your S wave is slightly higher than D, and you get this sort of short AR reversal. So greater than or equal to D. Sometimes in athletes and in people that are really fit, you can get your D wave being bigger, and obviously those patients don't have diastolic dysfunction, but generally if we're seeing S wave blunting and D waves being bigger, that's a suggestion with everything else that you've got some diastolic dysfunction. You also get it with moderate mitral regurg as well. You get systolic blunting with moderate mitral regurg, and then as you're getting to systolic mitral regurg, of course you're going to get systolic flow reversal. Generally your AR duration, so the time of this AR wave is about equal to your A prime or your A wave on your mitral inflow. And if this becomes longer than your A wave of your mitral inflow, then that can be a sign that you've got raised left atrial pressure. And that's something probably more for the ASE exam than the DDU vivas. But and then your AR velocity heights of less than 0.35 centimeters per second is normal. And if it's getting higher than that, then again, it can be a softer marker of maybe you're dealing with raised left atrial pressures. So as we were just saying there, all of the things that we said, reducing the scale, pulse wave Doppler about 1 centimeter into the actual pulmonary vein. Sample volume, I usually go more to about 4 millimeters for that, and then turn down the wall filters, and you get something that looks like this. So if you see this, what was your immediate thought with that?
So it's a different patient, I think, but S waves lower than the D waves is either raised left atrial pressure or it's going to be raised left atrial pressure. in diastolic dysfunction, it could be mitral regurgitation if it's eccentric and hitting the right target. But yeah.
Yeah, nice. Or it could just be like a normal, fit, healthy person, right? With
Yeah.
like an athlete where it can be the D wave can be higher. But can you see what Ben's just done there? So that he knows that because he's just looked at the systolic period here, he knows that that's the S wave, and this is the wave in diastole. This is our little AR that's just been a bit hidden down there. But this patient has systolic blunting, and as Ben was saying, you know, the main causes of that are diastolic dysfunction, or there's mitral valve regurgitation, or it could just be, you know, a healthy, young, fit person. So clinical context is everything, essentially, when you're putting all of this together. And yeah, so Ben, and that's just showing the pulmonary vein filling, actually. I should mention that these slides are from the late Andrew Hilton, who gave incredible lectures on diastology, and he made all of these animations, and they're really wonderful. So I hope you find them you know, useful. So this is the pulmonary vein Doppler profile, and this is where it's happening in the sort of Wiggers diagram, if you like. So you have the systolic wave here as you're filling from your pulmonary veins into your left atrium in systole, and then you're in diastole, you get your big D wave. So you see how the D wave, it's the D wave of the pulmonary vein that correlates with your, obviously, your E wave on your mitral inflow. And then your atrial contraction wave here in the pulmonary veins is obviously going backwards. And as I say, they should be equal in duration. And when this starts to become prolonged, then that can be a sign that you've got raised left atrial pressure, and the things that we just talked about. I think it's nice to see this because people often get confused with Doppler about where this D wave is happening, and don't really appreciate that this S wave is here in systole, even though it's called an S wave. It's still nice to have it, I think, mapped out. Ben, so this is your patient. What might you?
So going clockwise, we've got a woman with structural heart disease who's got an E over A greater than 2. So she's got grade 3 diastolic dysfunction. Her tricuspid regurgitant jet is 3.3, which is consistent, as is her medial E prime of 4 and her lateral E prime of 7, acknowledging also her caveats associated with measuring her mitral valve E primes, which is the calcification and whatnot that she has there as well, and potentially some reduced wall motion or something associated with that posterior mitral valve leaflet. So even putting those aside, she's got grade 3 diastolic dysfunction.
Yeah, nice, Ben. The only thing I would say is that I'm not sure this is an A wave, because I think she's not in a clear sinus rhythm.
Yeah, I guess I just looked at the top left box. I didn't look at where that cursor would put.
Yeah, so I mean, we might be getting a few little P waves or some sort of atrial activity because we've got some sort of A wave here, but it's quite, you see how it's irregular? It's like the space between this and this is different to that. So I think she is in atrial fibrillation. So obviously we wouldn't get this classic sort of.
Yeah. In that case, then, you know, if the point that's marked as an A wave is not an A wave, then she's certainly got quite an elevated mitral valve E velocity. That can be a few things in her. It can be from her diastolic dysfunction. It can also be from her mitral regurgitation, giving raised left atrial volumes, therefore increased preload of the left atrium before it empties into its left ventricle.
Nice, Ben. Really nice. But so you're not going to hang your hat necessarily on the E to A in this, but what other things that you've put together where are you going down in your algorithm with her diastolic?
So it's severe diastolic dysfunction with of her TR velocity and her septal and atrial E primes. We know about a huge left atrium, so that ticks those boxes.
Yeah, nice. So you're in the middle pathway, aren't you? Because we're not using her E to A. Because we're not using. I think that's an error in that measurement.
Yeah, but then if you're not using her E to A's, then you could never say she's got severe diastolic dysfunction despite all the other parameters, can you?
That's right. That's a problem with the guy. I don't suppose it matters because you want to know whether she's got raised left atrial pressure or not.
Which she does.
So but you're exactly right though. For the purposes of the guideline, she would fall into that middle category.
Yeah.
So then our E velocity is obviously way more than 50 centimeters per second. And what other things are you looking at in that middle category, Ben?
So then it's your TR velocity again and your E primes. Is your LAVI there as well? I think so.
We just had her LAVI, didn't we? It's like 50.
It's 1 million.
Yeah.
Yeah.
And what else?
An E to E ratio, E to E prime ratio.
Of more than?
14 if you go by the guidelines, but
nice.
If you read different books, we'll say different numbers.
Yeah, and obviously she's in AF as well, but yeah. ETE prime of more than 14, and then PRV max of more than
2.8 for the.
Very nice. So more that she's got more than 2 out of 3 of those, hey? Yeah.
Emma,
So she's in. Yeah.
would you see a possible L wave in the point that's marked as a A? Could that potentially be an L wave?
Yeah, really nice question. It could absolutely be. I've actually got a still of an L wave, so I might just bring you along to that just to skip through. That's an L wave. So I was going to ask spot diagnosis, what is this? But you're absolutely right. So we mentioned at the beginning about you have that rapid filling, and then you have that period of diastasis, and then you have your atrial kick. Well, in between that diastasis, if you've got really, really high left atrial pressure, you're still going to fill. You're still going to fill forward into your left ventricle because your left atrial pressure is really high, and that's why you get the L wave, which is really nice. They tend to have a cutoff of more than 20 centimeters per second to truly call it an L wave. And the other thing to realize is that it's not only raised left atrial pressures that give you L waves. In young, fit, healthy athletes, you can also see this phenomenon, this filling in diastasis as well. But really nice, and it absolutely could be.
Sorry, Emma, do you mean that? Sorry, I don't know. The L waves, are they normally less than 20 or greater than 20?
Sorry, Ben, greater than 20.
Greater than 20.
Greater
Cool.
than 20 centimeters per second, yeah. But the reason I showed this case, Ben, obviously she's got moderate diastolic dysfunction, maybe severe, who knows. But the thing that I wanted to highlight was how can you assess diastology with her severe MR? Because that's often one of the contraindications, right? You can't use your normal parameters in patients with severe MR or moderate to severe MR. So you have to take it all with a little bit of pinch of salt and sort of put it together with other things. But there are some other parameters in the guidelines that you can use to assess diastology in patients with severe MR. Do you know of any of those?
Yes. I did.
It's like
so yeah, if you've got significant mitral regurgitation, it will throw out, I'm going to work backwards, it throws out your left atrial volume. You can't fake someone's pulmonary venous waveform. So if they had global, like all 4 pulmonary veins with blunting, I'm going to say it's more indicative of raised left atrial pressures. It can absolutely
Remember, you've got severe, moderate to severe MR though. So what's that going to do to your? It's hard to use your pulmonary veins.
Well, I think it'd be if it was affecting all of them, I guess. So if it was like, because you've got eccentric MR, then it may not be going into all of them. I guess is my thought.
Yeah, I guess unless you have a toe examination.
Yeah, got a toe, right? And then I don't know whether you can do things like propagation velocities and things like that. I'm not sure.
So you probably don't need this for your DDU Viva, I wouldn't say, but it's more for there's a couple in the group that are doing their American exams, right? So that thing that we mentioned about the ART, and this is stuff small print that you just don't remember unless you're doing an exam, or you look it up. So you look it up when you've got these patients and you're scanning them, because you can never remember them, and there's caveats with all of it. But the ART at a duration of more than 30 milliseconds, or your isovolumetric relaxation time, we showed that at the beginning, of less than 60 milliseconds has a high specificity. And you can also do this ratio here, which I've never ever used, of your isovolumetric relaxation time. And then you remember I mentioned at the very beginning that as you get to more restrictive diastology, you do get that slight delay in your E wave to your E prime. So the time difference between those, your E prime starting to your E wave, you can use that in a ratio with your isovolumetric time. And if it's less than 5.6 and you've got a normal EF, then you can maybe estimate filling pressures in patients with mitral regurg. It gets more fudge factory for me, all of this. But I do like E prime because of its simplicity, and it's not perfect, but generally, if that's still more than 14 and you've got a patient with a bit of a dodgy heart, then they're most likely going to have raised left atrial pressure, when you put it together with everything else. I must admit, for practical reasons and simplicity, I prefer just still using the E prime. The same for patients in atrial fibrillation. E primes of more than 11 in patients with AF. With big atria and bowing of the septum and a bit of B lines and stuff like that, they're going to have raised left atrial pressure. And that's really, as intensivists and critical care people, we care about that, because we can change management based on that. So that's the isovolumetric relaxation time, as we talked about before, so from here to here. And this is the physiology behind it, right? So it's inversely proportional to your LAP. So if you've got someone with a really short isovolumetric relaxation time, it means that their left atrial pressures, because this is the time here that it's taking, so the higher these pressures, the shorter this time is going to be. And that's sort of the pressure volume, pressure time relationship to it, which kind of makes sense, I think. That's that there, and we know.
Is that sorry, Emma, for these all these parameters, if they are in severe tachycardia or atrial fibrillation, then how do these parameters?
Completely agree. Again, caveats, Ravi, because you're not going to be able to measure these out very well. You're going to get fusion of your E and A. It's going to be all a mess and out of whack when they're very tachycardic, and in AF and things like that. And you could still measure it potentially, couldn't you, in AF if it wasn't too rapid. You didn't have fusion, but it's really tricky, and that's why you can never use anything in isolation. It's just about trying to put the picture as together as best you can, with the clinical picture that you've got in front of you as well, which is crucially important, as you know. So yeah, no, I completely agree. Tricky, but do you see why this shorter relaxation time would be inversely related? So obviously your mitral valve's going to open when your left atrial pressure exceeds your left ventricular pressure, and the higher up this is, then the shorter that isovolumetric relaxation time will be. And Ben, your patient, just this one that we just talked about, had sepsis, and we know that diastolic dysfunction is associated with worse outcomes in patients with sepsis, perhaps even more so maybe than systolic dysfunction. And again, lots of work by Sanfilippo and colleagues, and this is a nice study by Landersberg actually, which just shows that they divide the patients up into quartiles, and I forget how many patients there were. I think it says here, doesn't it, how many there were, but it's essentially those with lower mitral annular E waves and higher E to E prime ratios, in the Kaplan-Meier analysis, had worse outcomes. So it seems to be important in patients with septic shock. So I'm sure you all know. I guess what we do about it is another thing. And I think we might leave it there, guys. There is this final case that I was going to talk through, but we can do that another time. We've got heaps more to talk about on other times. You already got the L wave there. Well done, Drew. So yeah, just to recap then, putting it all together in terms of that framework with the guidelines. Remember, guidelines are guidelines. You've got, patients are all different, and we've got to always put it into context. But in patients generally with a normal ejection fraction, so more than 50%, we are going to be looking at, for the reasons we mentioned, why we don't just include you can't use E to A ratio for the reasons I mentioned right at the beginning. So we use the average E to E prime of more than 14, septal velocity less than 7 centimeters per second, lateral of less than 10, a TR velocity of more than 2.8, and a LAVI more than 34. And if more than half of these are positive, it's diastolic dysfunction. If less than 50% are positive, then it's normal. And of course, we have this huge group in between. Probably most patients fall in this indeterminate category. Mostly in our patient group, I think we tend to need to use this framework a lot more. Most of our patients do have underlying heart disease, and we've gone through all of this during the talk, so I'm not going to reiterate that, but it's just a reminder for everyone. And maybe in the future, we don't know the role of LA reservoir strain yet in our patient group, but there's emerging data in this area. There's a lovely article by Smith talking about all of this if you wanted something to read next time you, I don't know, on the train or something. Then yeah, that's all really. So just a couple of cases to, I hope, emphasize to think about the guidelines and just have your framework really clear for that. This should be brainstem level. So everything on this sort of page here should be brainstem. The next step is then thinking about the other things that they're showing you, the clinical correlation, what that means to you in terms of your management, and then knowing those little caveats of, but this patient has severe MR, so I can't use that one. So therefore I'm going to look for this and this. Or this patient has significant mitral annular calcification, so my E primes are going to be down. I think that just gives you like that little cherry on top as well during the vivas, knowing those caveats. But it's really about knowing the simple stuff, the basics really well, and integrating that into the clinical context. That's going to allow you to pass the viva stems, and then the little extra bits are, I wouldn't worry too much about them, but if you can get that into your patter and you can sort of talk through them, then that's never going to be a bad thing either.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.